All right, we have a lot of folks that are tuning in, which is so great to see. So my name is Jessica Holsey with the Addiction Policy Forum, and thank you for joining us today for our webinar on recovery management checkups, an innovative approach to long-term substance use care management. We're really excited to share more information and introduce our speakers today on the recovery management checkup model. It's such an innovative approach to treating addiction and supporting individuals to sustain long-term recovery. Our speakers today include Dr. Mike Dennis, who's a senior research psychologist and the Lighthouse Institute director at Chestnut Health Systems. Also from Chestnut Health Systems, we have Dr. Dennis Watson, a senior research scientist, Dr. Christine Grella, a senior research scientist, and John Palmer, a linkage supervisor. A little bit about housekeeping. We will share a recording of today's webinar with all the registrants and also post that on our website. The slides will be available to all of our attendees and registrants. And please put your questions in to the Q&A box below on your screen, and we'll try to get it to as many questions at the end of the webinar as we can. So with that, I will hand it over. And thank you again, everyone, for joining us today.
Good morning, good evening, and afternoon, depending on where you are. My name is Michael Dennis, and I'll be talking today about the recovery management checkups. Next slide, please. So the goals for today are to describe the lift-up components of recovery management checkups, to provide you a case example and what we have learned from reviewing recordings of RMC linkage management sessions, and then to summarize our work with RMC in primary care settings. Next slide, please. So let's start with what is recovery management checkup. It's a chronic disease management approach to addiction. It consists of personalized, long-term, typically 12 to, we've gone out to 48 months, actually we've gone out to 4 years, monitoring, early intervention and re-intervention. And the goals are to detect as soon as possible needs and relapse. We want to shorten the time to treatment entry and re-entry if as needed, and to improve thereby long-term outcomes. Next slide. There are 2 decades of research with RMC. Go ahead and click it. This includes 6 clinical trials, 2 that are still underway, and 2 quasi-experiments. And these are publications. The slides will be available if you want to look at those, and or we're happy to share them. Next slide. Relative to services as usual, RMC across these studies is associated with higher rates of initiating care, reduced time between relapse and readmission, higher rates of engagement using the federal definition of 2+ sessions in the first 30 days, and continuity of care, that is, if they stayed in care 90 or more days, whether it's stepping up, stepping down, or just simple retention. It is associated with increased days and duration of abstinence, which reducing substance use disorder symptoms and a higher rate of remission, that is no symptoms in the past 90 days or past year. A reduction in HIV risk behaviors, illegal activity, violence, and high-cost healthcare utilization. It's also, when economists have looked at the cost of doing it, I've converted this to current 2024 dollars. Its cost of about $341 a quarter is offset by reductions in total healthcare utilization costs, less emergency room admissions, hospital stays, residential treatment, and so on. And even more so if you consider the tangible and intangible or victim cost of crime to society. Next slide. So what are the specific components that we use this acronym LIFT UP, which you'll be hearing about more when we go to the case study. The first is the idea of the linkage manager. They are the central focus of the intervention, the active ingredient. These are dedicated guides to support treatment linkage and recovery journeys. They typically have a minimum of a high school equivalent education. Some of them have BAs or masters. They lived experience is welcome, but not required. So we have a mix of both. They, regardless of their background, they undergo a rigorous training reviews of digital recordings, get feedback, and get certified that they have achieved a consistency in their delivery with the overall model. The approach is guided by individualized computer-based script, or what we call a worksheet, that helps you combine the information that you have from the interviews, what's happening during the linkage session, and guide sort of some of the next steps. They use this to develop personalized linkage plans, to schedule and facilitate appointments, to ensure engagement, that we don't just take them to the door of intake. We want to make sure they stay, and provide continuous support throughout the recovery process. And when needed, they relink them to treatment. If they've dropped out or they've had a period of recovery, but then have relapsed, we'll try to get them back in as fast as possible. Next slide. How do the linkage managers do this? Well, the next component is really, used to just call it motivational interviewing, but in all honesty, when you review the tapes, it's really inspirational. They're not just motivating people towards treatment initiation and mutual help or group. We'll try to get them to go to treatment. If they won't go to treatment, we'll try to get them to go to mutual aid. If they won't go there, we'll try to get them to commit to behavior change or harm reduction. We'll meet them wherever they're at and try to get them to go along that continuum. But part of what these guys are doing is inspiring and sustaining the patient's, participants' recovery goals. They're staying in the life, they're staying in the game. A lot of treatments only 12 weeks or less. These guys are staying with them for 1 to 4 years. That's a big difference to have somebody in your corner. The approach includes motivational interviewing, commitment to change, risk reduction strategies, consistent long-term supportive relationships. Next slide, please. Second thing that the linkage managers do is they follow up through regular checkups. If you had diabetes, heart disease, any other chronic condition, you would get checkups. Well, addiction is one of the 10 leading causes of death and one of the 10 leading causes of healthcare utilization. It is a chronic condition. So we set up personalized linkage and recovery plans. We have proactive client tracking model where we get them in every quarter. We assess the participants' current situations. We identify and address any treatment barriers that have happened in the past, including when we tried to link them. We develop a plan. We facilitate treatment linkage. We'll talk more about that in a second. We talk about behavior change and what they might do. And then we work on the next steps in their recovery journey. Even if they're doing well, we want to keep them there. We don't just say goodbye. Next. In terms of treatment connections, our goal is a quick treatment connection when the client is ready and willing. So to do that in advance, the linkage manager worked with the local treatment providers to provide a strong formal connection. They help clients successfully navigate the intake process and paperwork so they know what's going to happen, what they need to bring with them. They ensure that if they need ID or other information that they've got it with them. They'll arrange transportation for them to go to that meeting. If they need it, they'll even go with them to the meeting. They'll work out things for information sharing processes in both directions. And they'll also do a warm handoff, sometimes calling to help make the appointment in real time. Next slide. Again, going back to that relationship, there is this sense of unwavering and ongoing support. We want to ensure and encourage support throughout the treatment and recovery process. That means that when we get them to go to intake, we don't just back off because we dropped them at the door. We have an intense 2-week engagement protocol. We found early on in RMC that if we didn't get them to stay at least 10 days, 2 sessions, the federal definition of engagement, there was no effect of getting them through the door of intake. The only effect is if we successfulally handed them off and they stayed and engaged in treatment. We verify post-treatment engagement with the providers and or the participant. We continuous check-ins via call, text, or social media. We review progress and needs at quarterly checkups. Next slide. We also do proactive relinkage. We actively relink participants who have disengaged from treatment. We assess the reasons for disengagement. Was a client fit with the program, satisfaction, Maybe they needed a different treatment modality. We'll develop and implement a plan to address any issues that happened last time. And we'll provide continuous care to relink people to treatment. We'll do this as many times as necessary for it to take. Next slide, please. Now I'm going to hand it off to Dr. Grella.
Great. Thank you, Mike. So we thought in this part of our presentation, what would be most helpful after hearing the description of the RMC intervention and the lift up components would be to illustrate them with a case example. And I'm going to do that with my colleague, John Palmer, who is the linkage manager supervisor at Lighthouse. And we're going to use a case example drawn from our current JCOIN study. So JCOIN is a national multi-site initiative sponsored by NIDA to help individuals who are involved with the criminal legal system and have opioid use disorders access treatment. And in our study, we're working with people after they're discharged from jail. We're primarily recruiting our participants from Cook County Jail, and we're located in Chicago, although we have several other remote sites. And today we've chosen an example from our current JCOIN study, an individual named Joe. So we're going to walk through each of those components. But first, John, could you tell us a little bit about Joe, a brief description of him?
Sure. Yeah. Hi, everyone. So Joe is 64 years old, African-American male. His kind of logistics is back and forth between his mom's house, the streets. You know, he experienced lots of homelessness, in and out of institutions and couch surfing. He's got a reported 30 plus years of heroin and cocaine use, as well as other reported use, alcohol, marijuana, things like that. And he's got a long history of many attempts at treatment, whether it be medication-assisted treatment, detox, inpatient. You know, he's been in and out of a lot of programs. And with that, he's had a long history in the criminal justice system. Most of his charges are minor things, but they add up. And, you know, he's got a history of possession, shoplifting, trespassing, things like that that go along kind of with everyday use on the streets.
Great. Okay, next slide. So we're going to go through each of these components and see how they apply to Joe. So we'll start with linkage manager. And as Mike mentioned, the core of our intervention. John, can you tell us a little bit about, as a linkage manager, what was your initial goal in working with Joe when he came into the project? And what did you hope to accomplish?
So the main goal as a linkage manager at Lighthouse is to be that conduit to treatment services, if needed, and or, you know, that ongoing support, as Mike mentioned earlier. You know, Joe needed a lot of support because he felt he was stuck, right? So in his lifestyle and everything. So along with us being that treatment linkage and that support, you know, we kind of use motivational interviewing to push that motivation for change. So when Joe came to us, he basically, like I said, he said he was just tired. He was fed up. He wanted to have like two of the simplest things we might all think about: a job and a relationship with his mother and family. And you know, he was tired of not being unemployable and disappearing from his family's life, most specifically his mom. You know, when clients like Joe come to us, I mean, you know, we do a brief assessment to kind of figure out where they're at, what they're using, things like that. And, you know, that's when the linkage manager gets that information. And that's what we kind of focus in and hone in on: his reported substance use, you know, his goals, if there are any at first, and, you know, what he wants to do moving forward for treatment, basically.
Great. So we're going to move to the next component, inspirational and motivational techniques. Can you briefly explain what motivational interviewing is? Many people may be familiar with it, but tell us a little bit about what it is and how you were trained in it, and how we ensure fidelity. And then secondarily, how you applied MI in your work with Joe.
Yeah. So I like when Mike mentioned motivational interviewing, inspirational, because first and foremost, not only do we have the opportunity to provide any inspiration to our participants, they inspire me every day. Whether it's, so it's definitely that a big part. So I just wanted to do a shout out for that. So we use MI as a technique to help assist people in motivation to change behaviors. So we're all trained by an MI specialist who provides ongoing monitoring, support, fidelity, all these different things, whether it's group trainings with the rest of the linkage managers, private or one-on-one trainings. We're constantly refreshing and, honing our skills, and learning any new things, and always open-minded to learning new tricks, So it's very nice to have that access to such a really positive trainer that we have. So Joe, the behavior related around his substance use, and the troubles that came with it, whether it be legal, health, family issues, so I was able to utilize MI to get a better understanding of what Joe's intentions were. Part of MI, there's the spirit of MI, so we built, with partnership idea of it, just wanted to make sure that Joe and any other participant that I work with has an understanding that we're on the same level, right? It's a partnership. And when they, are able to grasp that someone else really, cares and wants to do this, it's really a freeing thing for them. So we kind of draw empathic listening. That's kind of a huge deal with the MI and how, I interact with Joe specifically in acceptance. There's non-judgment. We really like to isolate that idea with our clients and Joe specifically. I'm not here to judge. It's not my goal. It's not my point. I mean, obviously we're all human, but nothing can tell me is going to allow me to feel any different about Joe. Because he's, stand-up person. Compassion, evocation. We draw out his ideas, his goals through MI to see, and ultimately Joe was able to figure out on his own or through his own, it's tough for words, through his own, just recognition, he was able to draw out his own goals and realize that he has the power to fulfill these goals. Even though things seem so bleak at times when you're out there using, opiates specifically. So he was able, by the end of it, he had this amazing ability to empower himself for things. And along the way, we battled a lot of ambivalence. And that's one of the beautiful things about MI. Ambivalence isn't necessarily a bad thing either. We always like to say, listen, the fact that you're thinking about options is a beautiful thing, because some people don't, so that's basically how we utilize MI with Joe.
Right.
And
Great. And I think as we move to the next component, which is follow-up through regular checkups, the critical point is that we have ongoing contact through our RMC intervention, starting at the entry into the project and then quarterly. So tell us a little bit about why are regular checkups important, and how over time you worked with Joe, how things changed over time through these regular checkups over a full 24 months.
24 months. Yeah. So the regular checkups is kind of a twofold thing. One, they let the client know that we're there, and we go out of our way to not only make contact with them, but connect with them. We're constantly, not bothering, but in a sense, we want them to know that we are there to support. And if they may feel like they're giving up, I'm not going to give up. And Joe was definitely, definitely took advantage of, or not, he didn't take advantage. I took advantage of, my compassion for this job, and Joe was able to latch onto that. Through regular checkups, we get to follow along on their journey. This is a 2-year study. And, there's ups and downs, ebbs and flows, good things, bad things, and different kind of things, but we're along the journey with them. They're driving the vehicle and they got me in shotgun, right? With the seatbelt on, and I'm just kind of going along with it, and doing what I can to assist and support in any needs necessary, which can be, there are bumps in the road, there are relinks to treatment. So barring any outlandish circumstances, we let our participants and Joe know specifically that you can always go back to treatment. You're never banned for life, like I said, barring outside any something really wild. So, you know, so if there is a bump in the road, we can get them back into treatment.
Yeah.
Whether it's methadone, inpatient, whatever, you know, there's all sorts of options. So,
And excuse me, you met with Joe for fully 24 months and he, I believe, was quite adherent. He came to all the meetings, right?
absolutely. Joe showed
Yeah.
up to every single one.
Yeah.
In
Which
2
is
years.
quite impressive.
Absolutely. Yeah.
So moving to the next component, treatment connections, a critical component for us at Lighthouse is developing relationships with our local treatment providers. Can you tell us a little bit about how that works as a linkage manager, how you use the referral network we have, and how in particular you did that with Joe?
Sure. I'll start with Joe because for Joe, you know, he had some familiarity with treatment, methadone specifically, and he's been in detox and all that stuff. So part of the idea of the linkage meeting we have, you know, especially at first and throughout if needed, is discussing what type of treatment he's been on, what he, you know, his thoughts about things, what worked, what didn't, what he felt was not successful about certain things, you know, his experience or lack thereof. And through that, you know, that's where we come in, or I come in, you know, and using MI Spirit, educate with permission, you know, the idea of, you know, being able to answer some questions about, you know, Suboxone as opposed to methadone, things like that. We're all trained to know at least the basics, you know, the differences and the pros and cons that we hear from everyone else about those. So, you know, as we mentioned earlier, we are connected with lots of treatment centers around the city of Chicago and even outside. We have an amazing partnership with two of the biggest family guidance centers for outpatient methadone and Suboxone now, and then Haymarket, you know, for inpatient services and things like that. We're able to build and foster those relationships because we, you know, not only give them referrals, but, you know, I'm, you know, talking to a lot of the staff there, not necessarily daily, but weekly, just, you know, just checking in, you know, and seeing how clients are doing and things like that. And, you know, it's a great relationship we have. And so Joe, I kind of feel picked up on some of that because he trusted that if I was to link him someplace that would be, you know, it would be okay. And that there wouldn't be maybe bumps in the road, you know, outside of himself, I guess, basically.
And what kind of things do you do specifically to help someone show up at treatment?
Absolutely. So, there's several things we can do, and we do. First thing is transportation. There's a lot of barriers to treatment. A lot, you know, we can think of all different types. Transportation is arguably one of the top ones that most people will list as a barrier, and it's one of the most easiest fixed, right? We not only would call them, give them an Uber ride, basically door-to-door service from their place of residence to the facility, so they can get out and do their initial, you know, appointment, intake, assessment, all that stuff for the agency. But we help with any type of paperwork, anything that, you know, they might need. I think then, or Mike mentioned earlier, if they have IDs, if we need ID, you know, if they need an ID, things like that. We don't necessarily provide that service to get the ID, but we can definitely make sure we're sending, you know, Joe to the place as prepared as possible. So there's no, you know, last minute, like, wait a minute, surprises. So we kind of alleviate any of those worries as well. So
Great. So the next component is unwavering and ongoing support, which is, again, such a crucial part and a unique aspect of the RMC intervention. Can you give us some examples of the kinds of ongoing support you provided to Joe, and how you work over time with someone who may have relapsed or been reincarcerated?
I mean, yeah, that's one of the beautiful things about, you know, the longevity of our study. It's by far the longest intervention model I've ever been involved with. And I've, you know, had experience in counseling, crisis counseling with young adults, all sorts of things. So this is by far a long stretch of time, even though 2 years in the grand scheme isn't, but it's a lifetime here. So with Joe, you know, there were several ups and downs, you know, and especially in the beginning. I mean, I know I linked him to the methadone clinic. He went for a little while, you know, fell off a little bit. We were able to relink him there. And I think by the third or fourth time, you know, we decided to try something a little different. Through the idea of going to a detox and inpatient came up, and if he figured that that would be where he was at that moment, the best thing possible. And through that, he completed detox, he completed 28 days, and he advocated for himself without me or anybody else, the idea of switching from methadone to Suboxone. He came up with the idea that what he was doing wasn't necessarily working for him. So he, was able to advocate for himself, and switch medications. So that's I feel like a huge, thing to take on and to address. Through the partnership with the MI, we established lots of things. There's a trust. Joe knew he could trust me. He could trust that if I was going to say something, I would do it. Or he could trust that if he was to get into an Uber and I was going to send him somewhere, he would end up where we were going to send him, right? So there's a lot of things that, clients who first come here, we pick them up, we never even met face to face, right? And they get into a car and come here. And once Joe saw how the process works and everything, there was never any like lack of trust or anything like that. So there's always that support with the treatment. Yeah, and so over 2 years, there's lots of bumps in the road that can happen, but we were able to stay very consistent with our connection and our contact.
So the last component, proactive relinkage, you've really talked about a lot of this, how linkage managers are proactive. They reach out through their connections to the network of providers. You worked with Joe over time. So through the process of linking him to treatment over time, what kind of effect did you see on Joe, and how did that work as you saw him going back to treatment? Did he stay
Sure.
positive? Did he get discouraged? How did that work over time?
I mean, I don't want to, paint the perfect picture, but there were moments where Joe was discouraged, as we could expect, right? This is not an easy thing to tackle on. But for the most part, he remained positive throughout the whole entire course. He was always talkative. He always wanted to tell me something that happened or a story or something before we engaged in our actual, meeting. So there was always that, and every time we ended up laughing, just because that's just the kind of spirit he has, and so, he came to me or to Lighthouse, and the word the word I can come up with is stuck. He came to me stuck, and throughout the course of everything, he was able to kick in the 4-wheel drive and move right out of the stuckness, I guess, right? So it's amazing. He switched from methadone to bupe on his own, buprenorphine, Suboxone. We worked together on the idea of things, but he was able to advocate for himself and do what he needed. The relinkage part, like I said, it happens, but Joe was very motivated. I don't know, stuck to motivated.
Yeah.
Beautiful.
Well, and you worked with him and using MI techniques to help him
Absolutely.
harness his motivation to change his life. So as we've been saying, 2 years is such a long period to be able to work with someone. We can see how the chronic nature of substance use disorders aren't resolved within 30, 60, 90 days. So as you reflect back, how would you characterize Joe at the end of the 2 years compared to the beginning? And what were some of the major changes that you observed in him?
Oh, yeah, as we mentioned a lot of times, 2 years, a lot of things happen over the course of 2 years for Joe. Like I mentioned earlier, he came in stuck and he was able to stop that cycle. He was able to, see that he is employable, see that he, can stop this vicious cycle of, in and out of facilities and treatment and streets and drug use and all these things. And that, part of what we do is, with permission, we have collaterals and things. And so I was able to forge a small relationship with Joe's mom, right? So Joe's mom is a lovely lady. She, has health issues. She's, Joe's 64, so you can imagine, his mother's a little older. And, I remember the first conversation, she was like, what are we gonna do with that boy? What are we gonna do with that boy? And I was like, well, let's hope we have time, and patience to work with this, right? And she kind of took that and ran. And by the end, the last conversation I had with her, I was on the phone, but I could tell that she probably had a tear in her eye or something, you know, because she was like, I got my son back. I got my boy back. You know, and she thanked me and all that, and then us as you know, the Lighthouse Institute. But, you know, I was quick to say, listen, I'm glad we could assist and help. But, you know, Joe did this. Towards the end too, Joe, you know, was diagnosed with a very serious health issue. Very serious. And most of us would use that or that could be an excuse to say, heck with it. You know, I'm going to just continue to do, because now what's the point? And Joe being Joe, he was like, no, I'm not going to let this deter me, John, from where I'm at. You know, there was still some substance use at the end too. I don't want to paint a perfect picture of, you know, but Joe reported using so much less than he had been, and it was consistent to a pretty decent point. So that's the harm reduction right there. You know, we celebrate those types of victories because this is, you know, I don't know, it's a beautiful outcome. He was in treatment. He, you know, wasn't going to give up. He's using less, all these different things. You know, so overall, I think, you know, society, we tend to overlook people with substance use disorders, as if, you know, this problem doesn't exist. And Joe is now, you know, as we left, more than existing. You know, he was here, he has the motivation to change, and he's, you know, prepared himself to live. And that's a beautiful thing. And that's what happens 2 years with Joe.
That was such a great description, John. You really gave us a sense of the depth of your work with Joe over time, the structure of the meetings and how you leverage those to move through motivational interviewing. So just to close, tell us about what is the most satisfying aspect of your work as a linkage manager? You've worked with so many clients over the 5 years at Lighthouse, and again, you had ample prior experience. Tell us how you feel about your work.
I mean, the easiest thing to say is I love it, right? I also am human, and it's frustrating, and I have my own experience in the world of lived experience, and so I understand things. But I will say that forging these relationships is by far the most powerful thing about this type of model, the RMC model, and being able to just be that support to somebody. You know, I'm selfish in a sense. I'm like, I feel better if I'm helping others, right? So it's like a win-win, you know, for myself as well as the participants, Joe specifically. And there's a long list of participants I've worked with and continue to work with that are right up there with Joe in a lot of ways. But being able to be there along the journey and you know, embrace the successes. You know, if there's a lack of success, we don't dwell on it. You know, I don't dwell on it, and I try to through the best motivational interviewing type ways, you know, there's always tomorrow, basically, even though it doesn't feel like it. So that's the most gratifying part for me. And I'm not going to speak for anybody else, but I know universally with the linkage team that I work with, you know, it's just forging those relationships.
Yeah.
It's a beautiful thing.
Thank you so much, Joe. I was going to John.
Yeah.
You really shared a lot, and I think conveyed the passion and the commitment and the continuity that you express in through the RMC intervention. So we're going to transition now. We've been talking about applying the RMC with a population that's involved with the criminal legal system. I'm going to hand it over now to my colleague, Dr. Dennis Watson, who will talk about applying RMC within a primary care setting.
Thanks, Chris, and hello, everyone. And we can go to the next slide, please. So, you know, before I get into what I was going to say, I think that it's dawning on me that John did such a great job explaining all the work they do, but something that did not really come across, I don't feel like, is that all of the things that he's doing along the way are supported by a bunch of resources that form an infrastructure, as well as, you know, there's a lot of tools that they're using along the way and protocols that are being followed. And that is also part of the intervention. It's not, that helps to drive things. There's key relationships that have to be built with community providers. There's protocols for how often we're contacting people, making sure that we're staying in touch with them at an adequate level to form those strong relationships, things along those lines. And that's kind of foreshadowing where I'm going to go in a bit, which is talking about implementation of the model. So I think that, again, I'm switching to talk more about a primary care-based study in what we call RMC-PC, or Recovery Management Checkups for Primary Care. And, I'm sure if you're on this call, you're aware likely that tens of millions of people in this country are struggling annually with substance use disorders, and only a very small fraction of them are actually making it to treatment. Some of them, they want treatment, they want to get there. Some are not ready for it. And others just haven't even recognized yet that they may have a need for treatment, right? And primary care settings are a place that has been recognized as being good for helping to bridge this gap potentially, because many people in the US are in contact with a primary care provider who they may be seeing at least annually. And if we can implement procedures to identify potential substance misuse and have an intervention to get people into treatment, primary care settings can be really powerful for that. So the way this has been done traditionally is through something called screening, brief intervention, and referral to treatment, or SBIRT, which involves implementing some sort of basic, very simple, usually 3 questions, 4 questions that get at, is someone potentially misusing substances? If those get flagged, we would then have a little bit longer instrument that would help to understand if that patient, at what level that misuse might be at. Is it a mild, moderate, or potentially very serious misuse? And then from that point, if it's mild, they're going to hopefully be getting a brief intervention on the spot that's typically MI directed, motivational interviewing. And that's going to help to get them hopefully to see how their behaviors might be impacting their health, and begin to think about making changes. However, for individuals who might have a little bit more serious substance misuse issues, then we would want to move on to referring them to treatment. And when we're referring people to treatment, we know that this is the part of SBIRT that has typically fallen flat, particularly for individuals who are struggling with substance misuse other than alcohol. And that, this is because typically those referral processes are very passive. No one's following up. No one is treating this as the chronic health issue that John's description shows that it really is. And so what we wanted to know is, could we take an intervention that's rooted in this long-term model of supporting individuals and add that to the SBIRT model to help close that gap? And so that was a study. Next slide, please. That was the study that we embarked on. So the study of RMC-PC. This was looking at comparing individuals in an FQHC who received a federally qualified health center who received SBIRT, and comparing them to a group of individuals who received a sort of enhanced model of SBIRT that included RMC-PC as that referral component. So everybody in the study got SBIRT screening, and then if they were identified as having moderate or higher substance misuse issues, they were then referred to the study, and if they agreed to be in the study, they were randomized. It's important to point out too that all of these 4 FQHCs that we worked with for this study, they were already doing SBIRT. Many primary care settings, even though it is recommended as a best standard practice, are not doing screening or not doing SBIRT. That has a lot to do with implementation issues with SBIRT that I'll talk about a bit here. But it's not that easy to implement, even though the process kind of sounds like it's easy and flows pretty easily. So we had 266 patients enrolled who we tracked over 12 months. So this was a much, half the amount of time that John was working through our J-Coin study with Joe. If we can move to the next slide, please. And what we found from this was that on all of the outcomes that we were looking at, the enhanced intervention with the SBIRT plus RMC-PC those individuals did significantly better over the 12 months. So there was about double the rate of treatment linkage for individuals in that group. They were in treatment for more days, 54 days versus 27 for the ESPERT only. They had increased days of abstinence at 173 versus 140, and they had reduced days of substance use at 20 days versus 23 days for the ESPERT group. So we did also see that these outcomes held across some different types of substance use, alcohol versus other substances. This study was funded by the National Institute on Alcohol Abuse and Alcoholism. So it was beyond just looking at opioid use disorder as our J-Coin study that you had just heard about. And if we could go to the next slide, please. So this got us to thinking. We have this intervention, and as Mike showed you earlier, we have 20 years of evidence over multiple contexts with multiple populations, all coming to the same conclusion, and that this intervention really does work. However, we're very limited in that we have been doing this within the context of well-funded, very rigorous clinical trials, and we're not going to have a public health impact unless we're getting this out there in the world, right? So we are embarking now in asking the question, can RMC in general be delivered effectively outside of our shop, right? Outside of Lighthouse Institute at Chestnut. But we're starting a lot of those discussions with the primary care setting. And so if we can move on, please. So we started embarking on trying to understand answers to this question by conducting what was a very, very small feasibility study. We partnered with a federally qualified health center. They were in an urban location. They did not have any pre-existing ESPERT in place or substance use screening in general, other than if the physician decided, I want to screen this person, I think something's going on. So it was not a universal screening process. We wanted to partner with someone who did not have ESPERT in place, unlike the prior study that I described, because we realized that this is an implementation barrier that we're going to encounter in the real world, is that places are not going to have it in place nice and neat for us to layer on top of with RMC, right? This program also, it's important to point out, they had a very robust medication-assisted recovery program. So they did have the ability to refer people internally for opioid use disorder and alcohol use if they were interested in medication-based treatments. Also, within this setting, they did want to pair with us, going back to the ESPERT, because they had this goal of implementing screening for a very long time. So one of the benefits to this is that we said, okay, we're gonna teach you RMC, but we're also gonna hire and bring in a consultant to work with you to put the ESPERT in place. So we got a nationally recognized expert to come in and help implement the ESPERT as well. So our approach in this study was to implement the ESPERT first, followed by the RMC. We, worked with the organization to get that workflow for ESPERT set up, and then we focused on training an FQHC staff person who was a research coordinator. They had worked there for 3 years. I believe they started during the pandemic. And we were just coming out of the pandemic at the time that we were doing this work. And so she was trained alongside one of our research staff who was being trained in linkage at the same time. So they were trained together, and the idea was that the FQHC linkage manager delivered those services on site, where our linkage manager delivered a telehealth-based version. This is important because we're realizing that if this intervention were to stay just with us, the only way that we could really effectively scale it up is through a telehealth model. And so it seemed like a pretty fair comparison for us to do it that way. They delivered services to 16 patients, and we only did this for 30 days because our goal wasn't necessarily to see effectiveness of the model. It was to see if the FQHC staff person could actually do all of these protocols, use all these tools, and do everything that John was talking about just over a short period. We didn't want to overburden the FQHC at the time. And we compared outcomes between them and the research linkage manager. We flipped the coin. The first patient went to, I believe it was the FQHC, and then we alternated who got every other patient after that point. We conducted a final focus group with the people involved in that implementation. So the behavioral health care director, as well as one of the nursing managers, the FQHC linkage manager, and some other nursing staff and research staff that were involved. Next, please. And so what we found, well, we found a lot more than this with the service data, but I think this is the main thing that we took away from it, which is that we were hoping to just see sort of an equivalence in terms of the success of both linkage managers completing the meetings that they were assigned. So what we found was once someone agreed to participate in the study and they were consented, that after that point, if they were assigned the FQHC linkage manager, 86% of those individuals completed the baseline assessment, whereas only 56% with our research linkage manager completed. And we saw the same pattern where there was a higher 71% with the FQHC and a lower with the research at 56 again. What we really believe is going on here, we had qualitative data to back this up, other sources we were looking at, is that because that FQHC linkage manager was on site, they had an advantage in that they could flow directly from asking someone if they were interested into that assessment. Whereas in the telehealth model for our research linkage manager, they had to try to find that person after getting referred to them. Hopefully there was able that FQHC linkage manager who enrolled the person could at least introduce them by phone first. But if that didn't happen, we had to locate the person, follow up with them. There's a lot that can happen after the person walks out the door. We also think at the follow-up that just having that face-to-face contact was really beneficial at helping that the FQHC linkage manager form a relationship that got those individuals back in. Plus, it's easier to find people when they're coming in regularly for treatment on site where you work, right? Because these were all patients. They ended up all being patients in the medication-assisted recovery program, so they were coming back. Anecdotally, this linkage manager informed us at the FQHC that after 3 years, they had been delivering all of their research coordination, or not research coordination, treatment coordination services to patients by phone. They had never really met any patients. This intervention was the first time that they saw patients face to face. And it was the first time that when patients were coming in for treatment, that they were actually asking if she was there and if they could say hello. So she thought this was huge because she was forming relationships that she had never even thought she would experience with patients based on her prior experience. Next page, please. So we did have some challenges during this study that came out as things unfolded, but really got hammered home in the focus group that we did with everybody. We had screening challenges that occurred. We actually were not able to implement ESPERT at the end of the day for the study. We ran out of time. We were initially told that it would be able to be up and running in the electronic medical record within 3 months, and it took more than a year. So we did try to do a paper-based version of it. That just was not compatible with the workflow. And so it was really apparent that, at least in this setting, but probably in other primary care settings, having that integrated within the EHR is really beneficial. But there can be a lot of delays and challenges in getting that done if it's not already there, which is what we encountered. We also saw that there were financial barriers that got brought up. So during the focus group, it was discussed how this model is great. I'm going to show you some of the benefits they talked about on the next slide. But at the end of the day, they didn't see under current payment models within the state how this was going to be sustainable. And so we're working on that. But the technology challenges and the screening challenges were really the big things that slowed. It delayed us a few months. We tried to catch up, but at the end of the day, it wasn't possible. The positive end of this story is that the FQHC, because we helped them with training their staff and started this process, they were able to get ESPERT up and going after 12 months. It's running now, and they felt like this study was really what got them there to be able to do that. Next slide, please. So they talked about a lot of benefits that they saw of the intervention just after 30 days. So the biggest thing, and this was hammered home repeatedly by the behavioral health director, was that RMC is really compatible with the FQHC's mission to serve the most medically vulnerable, and that is often people with substance use disorders. Also, the fact that patients prefer a single point of contact was really, really seen as a huge benefit of the model, especially individuals who are misusing substances that may have a lot going on that can be difficult for them to manage in their lives, that just having one person that they can call and they know they're either going to pick up or return that call is really, really important for them. They have more support than usual care was offering them, which they thought was great, and that led to more intense and consistent patient contact, which they felt could have a huge impact on improving retention for them. Their retention was about the same as it is nationally for their medication-assisted recovery program. They're hovering around 50 to 60%, but they're really looking for ways to improve on that. And they felt like this model could help them get there. The linkage manager was able to manage the existing workflow. So this is really what we wanted to learn over that 30 days is could they do this workflow in the FQHC setting? This person was also still managing their regular job in those 30 days, and they were able to do it with a small sample and qualify that, right? A small handful of people. But one of the goals that we would have is that someone wouldn't have to wear two hats and that we could fund this in a way that RMC would be delivered by someone who was a single full-time linkage manager or multiple people who are working in that setting as linkage managers. And then connecting back to the fact that this linkage manager felt that they had formed really strong connections with their clients they'd never seen before, that they felt more helpful and motivated. And they said during the focus group, I like to feel helpful and to feel like I've accomplished something and to also feel like I've been part of somebody else's change. And that was really great to hear because my biggest fear going into this, that I was going to burn out this really amazing staff member. I'd worked with this person in the past on another study, and I did not want to put them in a situation where they were like, if I feel like I can't handle this, my work is stressful, and she felt it was really manageable, and she felt she got a lot of benefits out of participating in this. Next slide, please. So where do we want to go from here? Well, the path forward for us is we want to investigate the ability of FQHCs and other primary care settings to provide RMC directly. We want to help places implement it well. And this is also other settings we'd like to branch out, but right now we're just really kind of focusing on FQHCs in primary care. We are developing an implementation strategy to help us overcome the barriers we identified that I just talked about, as well as other barriers to scalability that we recognize are there. And we are investigating RMC-PC as a potential ESPER alternative. So again, rather than having to go find a place that has ESPER or implement ESPER first, can we just implement RMC-PC within the setting without having to do the entire ESPER process along the way? And we are also currently engaging a payer and provider advisory board. That board will be helping us to think through how can we be creative about how to fund these positions in this model, as well as how can we think about potentially from a value-based care perspective, supporting this intervention, and could we think about ways to advocate for changes in state Medicaid policies or other places that will help us to fund this intervention and similar interventions. There's a lot of movement right now in the community health worker space that we think is really exciting, as well as the peer recovery support specialist space that might provide avenues for funding this intervention in primary care and other settings as well. And next page, please. So if anyone out there is interested in being part of an implementation study, particularly, primary care, but we're interested in hearing from anyone, this QR code gets you connected to me through email, or you can make your own email with my address. You can contact anyone on this, webinar today, and we can connect you. But we're looking for places that would be interested in participating in an implementation study. If we are able to work with them to submit an application, then one of our goals, through this funding would be that we would be able to have the implementation supported through the grant. So we would be delivering a free package of implementation supports to help anyone who's interested to implement the model in a primary care setting. But we are also interested in talking to organizations that are just interested in thinking about implementation of recovery management checkups, what that might entail. We're trying to possibly develop a learning collaborative over the next year to think about these issues and help places. So anyone with any interest, please reach out. We're really interested in hearing from you, and that's it from me.